My name is Anna Lembke, and in this podcast we are joined by a real-life patient whom we're going to call Laura. Laura's story encapsulates the experiences of many patients that we've seen over the last several decades. Opioids are prescribed for chronic pain by a well-intended physician. The dose escalates over time due to tolerance. The pain does not improve after years on ever higher doses. The patient's function declines, and the final step of tapering off looms larger than Mount Everest, a seemingly impossible climb. Laura's story begins early in her adult life, long before she encountered her first opioid.
It started my sophomore year of college, so I was 19, and it started as just like a burning kind of pain in my lower abdomen. At first, the pain would just come and go. It'd last for like a week, and over time, it became more of a persistent pain. It started to just become every day. I'd go to bed with it and then wake up and it's still there. I had a lot of tests at that point on just all the internal organs in that area, like my bladder and like reproductive organs inside, and had tons and tons of blood tests and all that, and they couldn't find anything.
During that time, Laura saw all kinds of specialists referred to her by primary care.
Rheumatologist, neurologist, endocrinologist.
Pretty much everything was always normal.
Not knowing it was wrong, I was worried that there could be something really wrong or even like something life-threatening. But then I started developing, like the depression as well, lightheadedness, which also like caused some visual changes. I became hypoglycemic, which doesn't sound like much, but I discovered that did affect things and affect pain, like it comes on really quickly and then I have to eat. So that weakness and being really sensitive to just sensory overload that I didn't have before, just auditory and visual.
Laura was at a loss to find doctors who were compassionate about getting to the bottom of her invisible illness. Someone to say,
okay, I'm with you on this, let's figure this out.
She found that doctors would either be casually dismissive or borderline insulting.
There were some doctors that were just like, yeah, okay, you're fine. I had one who told me that it was in my head. In about 2006.
This was after she gave birth to her son by C-section.
My pain got a lot worse. I think my body just could not handle that. So I started pursuing more doctors again, because I would kind of go through periods where I would really be hitting it hard and trying to be like, okay, we need to figure this out. And then we just get so sick of trying to figure this out and I would like to kind of try to put it to the side a little bit. I had tried so many medications, particularly antidepressants and, ones that were known to help with pain. So I felt like I tried everything, and I was very sensitive to side effects, so I wasn't able to tolerate. And looking back, maybe some of them if I had taken for a month or something, or rather than a couple of weeks, maybe I would have gotten used to it more.
Many patients with chronic pain are acutely sensitive to somatic changes in their bodies, and thus can experience side effects from medications like antidepressants, making the use of these potentially valuable medications more complex. Because of this, patients and doctors sometimes give up on these medications earlier than they should. Previous doctors had diagnosed Laura with fibromyalgia, but the most recent doctor, a neurologist at UCLA, didn't seem to think so.
She kind of made up a diagnosis, and she called it chronic regional sympathetic pain syndrome. And she explained it to me in the best way that I had up to that point, just talking about how my brain was just in this perpetual, cycle of sending pain signals to my body. And she was kind of like, at this point, I don't think it matters what caused this. You're probably just going to have this, like, probably forever, and you're just going to need to learn to deal with it. And like, you need to fight it, don't let it take over your life. And
the neurologist had stressed things like healthy eating and regular movement.
I felt like she understood it better than people previously had. So after a couple of visits, like, she was the one that actually did start me on the opiates.
Initially, the doctor only prescribed a couple of Vicodin tablets, which Laura found immediately helpful. It was the first treatment intervention that seemed to help with her pain.
Over time, it did stop working as well, and so this same doctor switched just the regular Vicodin to the Vicodin HP.
Which stands for high potency, though it also contains hydrocodone and acetaminophen. Soon thereafter, Laura switched her care to a primary care doctor who continued to prescribe Vicodin HP.
I actually really liked him. Like, he was validating and listened to my concern, like really listened, like, because this was an HMO, so it was like 10 minutes, get in, get out. And this guy, he would make sure that all your questions were answered. So that was refreshing, and I really liked him. Felt like, finally someone is actually listening and cares.
It's noteworthy that this doctor, whom Laura perceived as the most compassionate, was someone who had little time to spend with her but was still willing to gradually escalate her opioid dose. Eventually, the new primary care doctor added OxyContin on top of the Vicodin HP due to her still recurring pain, although it wasn't enough to cover all of it.
I think I probably started on 2 OxyContin a day, 20 milligrams, and eventually over time it became 4.
Like many patients, Laura started on a small dose of opioids, but due to tolerance, needing more and more to get the same effects, her dose went up over time.
At first, I felt like the opiates worked really, they worked pretty well, like, because they definitely, relieved the pain, and it was so nice to have a break from the pain.
While it's likely that opioids initially helped Laura's pain, after developing tolerance and physiologic dependence, she at some point actually began medicating withdrawal from her last dose rather than treating the underlying condition for her pain. In fact, chronic opioid therapy can make pain worse over time as a result of altering the pain threshold in the brain.
The pain was worse, like it would come back worse. So I was definitely becoming more, sensitized. And I would feel like the medication would work better if I took it when I was laying down and just like could relax all my muscles. And so that became kind of my pattern for taking the drugs, if I could, if I was at home, is to go lay down and take it.
A common phenomenon among patients taking high-dose opioids is spending more and more time in bed and less time participating in daily activities of living. Motivation was a big struggle for Laura. Eventually, the pattern became so routine that even her husband began noticing the shift. Over time, Laura's functioning deteriorated to a new low. She was spending all day in bed, and her depression got worse too. But she never made the link between her function, her depression, and her opioid use. Indeed, she was scared to not take opioids, believing they were the only thing that helped her pain.
So I was terrified because the pain it felt a little bit different. Like I felt like it kind of changed. It was still like burning, but this was more like of an intense, like gripping, like all through the muscles. But I was just so scared. I just felt like, well, there's no way I can do that. Like, I'm barely able to function in life as it is. I don't want to be on these. Like, I know they're not good for me. And I would ask my doctor, the internal medicine, like my primary care, And he would tell me that that it was okay, that they were checking my liver, kidney function every so often. And he said that he'd had plenty of patients that have been on these for years and years and years.
This doctor's approach is consistent with what doctors were taught about pain in the 1990s and early 2000s, which was that the risk of getting addicted to opioids prescribed for pain was less than 1%, that no dose was too high, and that the benefits outweighed the risks. In short, keep prescribing. The pharmaceutical makers of opioid analgesics played a big role in misbranding opioids as less dangerous than they really are. But today we know that the risks of opioids taken daily for weeks to months far outweigh the benefits. For patients like Laura, this wisdom came a little too late.
I knew that I was dependent. Like if I was ever close to running out, it's like I would get that motivation to go drive all the way out to where he was. But I didn't really feel like I was super emotionally dependent on them because I always took them how I was prescribed to take. So it wasn't ever like scary in that way. They did help mentally after I would take them. I would feel more motivated, but that only lasted for so long, like a half hour or something.
Laura's experience illustrates the complexity of distinguishing opioid dependence, which is a physical need for opioids to avoid the pain of withdrawal, from opioid addiction, a more complex psychological and behavioral problem. Laura never met the diagnostic criteria for opioid addiction, but she certainly was physically dependent, and the psychological dimension of her dependence perpetuated the problem. After living in their previous city and home for 11 years, Laura and her family made a move out to the Bay Area.
There were so many different changes. Like I didn't have doctors yet, and I didn't have anyone who wanted to fill the dang opiates. Like I really couldn't find anyone at first, and that was scary. And I just think all this anxiety built up.
She and her family went on a trip back to visit relatives, but during the vacation, Laura found herself terrified at the thought of not being able to get her opioid prescription filled or having to lower her dose over time. Her anxiety got so bad she couldn't get up out of bed even to take a shower. She felt like she was going to die.
We ended up leaving the trip early, coming back here, and just pretty much drove directly to Stanford ER because I didn't feel like I was going to harm myself or something like that, but I felt like we need to do something. We need to have a team of people helping me, and so I was admitted to the behavioral unit at Stanford,
the inpatient psychiatric unit of Stanford Hospital,
to treat that anxiety, and also I wanted to find someone that would help me basically prescribe the opiates and figure out what we were going to do about that.
The doctors in the hospital were concerned about the high doses of opioids Laura was on, now more than 120 morphine milligram equivalents daily, well above the range that the CDC considers safe.
They felt like it was hard to treat the mental symptoms while being on all the opiates because it's hard to add new medications because they're so sedating, and also they just felt in general that would be best.
While Laura was in the hospital, her doctors began the process of tapering her off opioids.
It was the most intense, crazy pain I've ever had. So definitely a 10 in that way, but beyond that, it was the worst pain, even basically that I could imagine. It was crazy for the first night. So that was extremely scary. I just felt like I was on fire basically throughout my whole body. So the next morning, when the doctors came back, I was just like, I can't do this. There's no way I can do this. And, they saw me crying and everything. And so they they adjusted things and it became a lot better after that day. I was still in a lot of pain, but it was like I could at least do it after that. They probably didn't even have to change it that much. It was maybe just my body going crazy after, just screaming for the opiates.
After a total of 3 weeks in the hospital, Laura's opioid dose was down to 40 morphine milligram equivalents daily, a much safer dose. This kind of rapid taper is easier to do when patients are hospitalized than it is on the outpatient side, due to the wraparound support and medical monitoring. For Laura, the plan was to taper the rest after discharge, but it was a struggle. Her pain would get worse temporarily with each dose decrease before leveling off again.
Ended up being a little faster than I could do. I did keep decreasing, but had to go much slower. And it was like a balance between that and, how I was feeling mentally.
It ultimately took Laura nearly 2 years to taper completely off opioids, and the last stretch turned out to be the hardest.
So it was just so difficult and debilitating again, and 10 plus pain that I had to slow it down so much that it would have taken, like another year to do it. And so I decided to go do the rest of, come completely off of everything in the hospital again, but this time in the SKIP program,
which stands for Stanford's Comprehensive Inpatient Pain Program. There, Laura went through a brief 1-week period of hospitalization to get completely off the opioids.
The pain again was very similar to the first time in that it was just an intense burning throughout the whole body, and it feels like, like you're on fire, but it feels like everything inside is, it's like cut up or bleeding, just everything's raw and, terrible, kind of like a gripping, like it's a very emotional type pain too. Like it makes, more than any other pain I've had, it's very depressive type pain.
A key ingredient to Laura's success in getting off opioids was learning new coping strategies to manage her pain.
I wanted to be able to progress with the new skills I was learning. I eventually started taking DBT.
DBT, which stands for Dialectical Behavioral Therapy, emphasizes learning about the triggers that lead to reactive states and assessing coping strategies for each unique sequence of events, thoughts, and feelings. When paired with the taper process, DBT is a non-pharmacological way to help patients cope with pain. Techniques include mindful breathing, mental distraction, and mind-body work.
Because it's hard in the hospital because my pain does get worse if I'm not active. It's such a hard balance. So I had to force myself to move.
After being discharged from the hospital the second time, Laura was completely off opioids. In truth, her pain in the month after the hospital discharge was intense. She also experienced significant depression.
Up to that point, I had not felt a real deep type of depression and anxiety that is just the worst thing you could possibly feel, even more than the pain, which I, couldn't believe I would say that at that point. So I was not just running from the pain, but also, the physical pain, but also the emotional pain. So I just made myself move. I made myself live moment to moment. I would plan my days, and I'm not a planner. That is hard for me to be structured and writing out a schedule. That's what my DBT therapist is always writing me on. But it's kind of how I need to live now. So still working on that, but became a lot better at that.
After a month off opioids, Laura's condition began to improve. It would take another 6 months before she could say that she felt better than she did on the opioids.
I feel like on an average, overall average, I've been rating my pain every day, and I've been saying 4 to 5, which is actually good for me. I mean, for what it's been in this past year. So hopefully it'll just, keep trending down that way. Because I still feel like I'm very sensitized, like as far as sensory, like the pain can spike in a second. And so it feels like my brain is still like this very sensitive brain in this transition.
In addition to improved pain, Laura has an entirely different approach to self-care than she did while she was on opioids.
I mean, the goal is to not really even lay down at all. It's difficult because it's so much more comfortable for me to lay down, like for a rest, than just, sitting on the couch or something. So it's way, way less now. I try to be doing something for, throughout the whole day. And I also try to be a lot better about sleep schedule, so going to bed earlier. So I am being awake much more and doing a lot more, and I hope my goal is to just have those become habits and just more automatic for me, not as having to try so hard all the time. It's only been a year, so it's making a major life change like that I know takes time.
Today, Laura struggles with pain every day. But the pain is at its lowest point in over a decade, and perhaps most importantly, she is re-engaged in her life. She's an active member of her family, she's exploring new career paths, and she's even considering having another child. It took tremendous courage for Laura to get off opioids, for it was a long, hard journey. Many of us in the healthcare profession underestimate how labor-intensive and difficult it is for some people to get off of opioids, even in the absence of addiction. But we can play a crucial role in helping our patients get off opioids, so I urge you to watch the associated videos in this course, which will unpack Laura's story and link them to key strategies in helping your patients taper off chronic opioid therapy.